and our topic today on the topic of when to refer to the hematologist. And so first, I just want to share the disclosures for those of us who are involved in preparing this lecture and series. So you can just take a moment and review this slide. Okay, and I think you can go ahead and advance to the next slide. So again, it is my sincere pleasure to introduce today my colleague who I work with here in Colorado, Dr. Genevieve Moyer. Dr. Moyer attended medical school and did her residency at the St. Louis University School of Medicine. Earlier in her career, she studied venous thromboembolism, the characteristics of individuals who receive stem cell transplantation, focusing on differences between cord blood and non-cord blood recipients. This led to her discovering that not only was post-transplant thrombosis a serious problem, but that these patients were at an extremely high risk of bleeding with anticoagulation. That really sparked her career interest aimed at developing tools to help risk stratify complex patients and their risk for bleeding and clotting together. And so as her career progressed, she realized she had a passion for the treatment of women with bleeding disorders, which is how our paths crossed, which has led to really her goal of overall balancing the knowledge and understanding of bleeding disorders across genders. Dr. Moyer believes strongly in the importance of getting to know each patient as an individual and engaging in a shared decision-making. To accomplish this, she strives to ensure that all of her patients understand the diagnosis so they feel empowered to really take care of their own health. Her medical specialty is classic hematology with an emphasis on hemostasis and thrombosis. She's committed to improving the management of women, transgender and gender non-binary individuals with bleeding disorders. Her primary research endeavors have focused on these populations with really the overarching goal of trying to develop risk stratification tools that can predict future bleeding and thrombotic events and therefore guide our medical management. And with that, I will let Dr. Moyer proceed with our sort of pre-session poll.
All right, so I'm going to read these off and you guys can, I understand, just answer them sort of on your own. The first question in this poll is to please indicate whether the following statement is true or false. Factor VIII levels can fluctuate depending on the stress level of a patient. So true or false there. Question number 2 is all of the following are recommended evaluation steps for an OB/GYN provider to perform when assessing heavy menstrual bleeding before referring a patient to hematology, except. So which one of these is not recommended to be performed? A, CBC and ferritin, B, a Beighton score to assess for generalized joint hypermobility, coagulation tests, including PT, PTT, and thrombin time, von Willebrand panel, or platelet aggregation studies. And number 3, what should patients not be advised to do while waiting to be evaluated by a hematologist? Review family history, track menstrual period, completed bleeding questionnaire, or stop taking any hormone medication. I'm sorry, there is one more on here. Inquire about insurance authorizations for specialty services. And do I end this or will somebody else end this?
I'll end it. I think if we
Okay.
could just give it 1 minute so that anybody else
sure.
can respond.
And really the purpose of this survey is just to help us get a sense of kind of your overall kind of comfort in this topic, kind of knowledge base, and then just to kind of see afterwards if we've been able to kind of change your thoughts on referral to hematology and again, potentially spark any additional questions.
I think I'll go ahead and end it.
Okay. Do I go through these or go through them at the end?
We can go through them at the end.
Okay. In that case, I will go ahead and advance and get started. So yeah, this session is focused on building a bridge between PCP or gynecology, identification of a patient with a potential bleeding disorder, and getting them into a hematology specialist. As most people probably know, Dr. Hughley and I work together in a multidisciplinary clinic to care for individuals with heavy menstrual bleeding who may have an underlying bleeding disorder. And so we see a lot of these patients directly as part of that kind of first specialty assessment. And this is sort of me as a hematologist coming to you guys to sort of try to bridge that gap of what to do in between when you guys see them and when they land on our doorstep. I'm going to really try to focus on three main things, understanding that there's a lot more that could probably be covered in just the 15 minutes that we have here today, but really trying to focus on the most important things. What are the barriers faced by referring providers? What are the things that those providers can do in the interval before they get seen by hematology? And what can the patients do themselves? All right. So the first barrier, I think, is one of the most challenging, and that is really trying to get a sense of what is your level of concern that there is an underlying bleeding disorder. Von Willebrand disease is by far and away the most common bleeding disorder, the most common thing that you may encounter in your clinics for girls who are having heavy periods. Hemophilia A is another condition that involves a factor level that may be just as complicated as von Willebrand factor. So von Willebrand factor activities and factor VIII activity, if you order a test on any given day, that's only just going to be representative of where that patient is at on that given day. Only 2/3 of any variability seen within a patient's von Willebrand factor and factor VIII activity are actually due to their genetics, and so their underlying sort of characteristics of their disease. And 1/3 is due to anything else that that patient is experiencing on a given day. So pregnancy and hormone exposure to particularly estrogen are notorious for increasing von Willebrand factor activity and factor VIII activity levels. Stress can also do the same. So even just the kind of stress of coming into a doctor's office to have to meet someone new or talk about uncomfortable things like having heavy periods, or a lot of patients have needle phobias and really are afraid and nervous when they know they're undergoing to go phlebotomy. All these things are stressors that can increase factor levels, but physiologic stressors such as surgeries and acute illnesses can also do the same. We know that von Willebrand and factor VIII activity levels increase about 2.5% per decade. So it's very common as someone ages for those levels to go up. And then even time of day, what kind of a meal someone has eaten can also have some variability. So it's really hard for us to ever know what a person's true baseline is. And we'll always be repeating these levels just to really try to get a better sense of that. And it means that the time that you may choose to see, hey, I think this person maybe has something going on, and you check von Willebrand levels, even if they're high, that doesn't necessarily rule out a diagnosis of von Willebrand disease. So that's a problem with fluctuating levels. Pre-analytical variable errors are also quite common. So this is a scenario where someone gets their blood drawn and maybe the lab, there isn't a coagulation lab on site. And so that tube may sit on the counter in the sun for a half an afternoon before it gets sent off to the processing lab. And those proteins can get broken down in the tube. And then when they go to be processed, end up actually coming back much lower than they are in the patient's body. So this is one thing that can interfere with the tests, but we also know that there's a lot of variability just even within the tools, the machines that test for these activities as well. So what you're seeing here is sort of a trial of really trying to get a determination of the variability of factor VIII and von Willebrand levels when we know what the von Willebrand level is. So these are coming from a pool of samples where we know, so for these here that are all labeled 4, that there's 100% von Willebrand factor in that particular pool. There's a separate pool also with 100%, and then the pool 4 is diluted to get these lower percent of von Willebrand factor samples of 70, 50, 30 ongoing. So they have these tubes with known amounts of von Willebrand factor activity, and then they send them out to 11 different labs across the country at hemophilia centers with coagulation labs. And what you're seeing here is the variability in what those von Willebrand factor activity levels are reported by those institutions. So you can see that there's really quite large amounts. And particularly in this case, you could see this tube had 100%, and somehow the number came back even higher, which really doesn't make any sense. But it just really goes to show that just as patient variability is a problem, even the tests that we have to really assess for this disease are far from perfect. Also confusing is behind the scenes as hematologists, we're always changing what the diagnostic criteria is, making it even more confusing for you to know what qualifies as a diagnosis. At the current stage of things, von Willebrand disease is defined as a von Willebrand factor activity level of less than 30%. That's sort of regardless of any clinical history. Or if your levels are between 30 and 50% and you have an abnormal clinical bleeding history, that also gets you a diagnosis. However, we know that there are patients that have levels in the 60% range who can also bleed. So this is, always kind of comes with that caveat. Additionally, mild hemophilia can be defined as any factor activity levels less than 50. This is also in some places reported as less than 40. But the point is, for a biological female who has an abnormal factor 8 gene on one of their X chromosomes, if their levels are less than 50%, they qualify as having mild hemophilia. They're not just carriers, they can be, we know, very symptomatic, particularly when levels are lower. Someone with higher levels, so let's say 60%, and they're known to have a affected factor 8 gene on their X chromosome, we would call them either asymptomatic or symptomatic carriers. That is a term that will probably still undergo additional changes in the future just due to the stigma that is associated with that word carrier, which kind of implies unaffected, which we know is really not always the case. Additionally, now there's this new category, somewhat new category of bleeding disorder diagnoses that we've labeled bleeding of unknown cause, which is a scenario where we know that people have abnormal bleeding, but we do every test on their son and we still can't really figure out a reason why. These patients are still at just as high a risk of having future bleeding events as individuals with known von Willebrand disease. So this really is a real condition, and it speaks more to, I think, our field's lack of ability to diagnose all of the bleeding disorders that are out there. We are limited in the tests that we have and our understanding of disorders other than the ones that we've already classified. So those are all the things that can make it difficult. What can you do to sort of overcome those difficulties in trying to assess whether there is an underlying bleeding disorder? There are some clues that can give it away. So people who are really, truly severely iron deficient, that indicates ongoing bleeding that would certainly be expected to be more than heavy or more than typical, especially if someone is having normal menstrual cycles and is not anovulatory. If they have a strong family history, so 4 generations of biological females in a given family all have terrible periods and have to have early hysterectomies, that's sort of a red flag. If they have other bleeding symptoms, so if they report that they have nosebleeds or they're bruising like crazy, or they've had surgeries or dental extractions with other bleeding events, that can also be a good clue. But I would also like to say, don't discredit your own medical gestalt. Sometimes there's just a feeling that something seems not right about this patient that I think is a really important clue to pay attention to. Even if all of the tests that you do are normal and by the book, there's no obvious reason that this patient can be proven to have a bleeding disorder. If you get that gestalt and just some kind of concern, those are still patients that we want to see and evaluate as well. So once you feel like, okay, yes, this is someone that I really need to refer to see a hematologist, where do you go from there? The first thing that I would probably recommend you look for is a hemophilia treatment or a hemophilia and thrombosis center in your area. There are 141 of these across the country. I know we have a pretty widespread, but you can see for those who are in New Mexico and Arizona, we have a little bit more sparse HTCs than on the East Coast. There are outreach clinics that these individual institutions will do if you're not in one of those locations, but it really is probably the best first stop for evaluation of a bleeding disorder, mostly because these centers are staffed by multidisciplinary team members who are specially trained for the treatment of hemophilia and the associated conditions that can come along with that. So oftentimes they'll also have physical therapists, social workers, psychologists, pharmacists, research teams that can all engage with the patient to make sure that they really are optimally engaged. And if they are ultimately diagnosed, then they have access to the medical treatments that they need, and also specialty nurses that can help coordinate surgeries and things like that. Because not everybody can be seen at a hemophilia treatment center, the next step after that would be a community or academic hematologist. As many people probably know, hematology and oncology are combined into one fellowship. So very often individuals will do both, but sometimes someone may do mostly breast cancer medicine, and they also technically see patients with bleeding disorders. So they may only see 2 or 3 von Willebrand patients every couple of years. So identifying someone who really does treat a lot of patients with bleeding disorders, or what we call classical hematologists in the community, would be the next best step, followed by that oncologist hematologist if you're unable to identify someone with a hematology specialty. Even oncologists, even someone who treats breast cancer every day, will have had training in bleeding disorder management. How urgent is this referral? How nervous do you have to be about really advocating to get that person seen right away? There are some things that should increase your level of concern to try to expedite that referral whenever possible. Obviously, anemia, especially if you don't feel like you have the resources at your center to adequately treat that, or if their bleeding is really uncontrolled and you know that anemia is just going to continue to get worse because we haven't controlled the underlying cause. If someone just happens to casually mention like, oh yeah, I'm gonna get my wisdom teeth taken out next week too, or any other kind of upcoming procedure, that's something that should expedite the referral so that if a bleeding disorder is identified, they can be supported during that intervention. And then quite obviously, if they're having uncontrolled bleeding from other sites, you think that looks like they're having bleeding into their joint, or they're having GI bleeding, anything like that. These would be things that we would want to not just have a referral place, but really try to hound the center to get them seen as soon as possible, or even be seen in an emergency room setting where there may be easier access to a specialty hematologists. So those are all the things that sort of can get in the way of really knowing what the first steps are to take. But once the referral is made, you've got this patient set up in a hemophilia center. What are the things that you can do in the meantime before that person is seen? The first thing, if this hasn't already been done, is what we call a first-tier hemostatic evaluation. This is your basic coagulation tests, including a thrombin time or fibrinogen. Both of those are really kind of measuring the same thing. And then, of course, as we've discussed, our von Willebrand quote-unquote panel, which also includes a factor VIII activity, because we know factor VIII activity is also low in von Willebrand disease. But then also a CBC is important to look at the platelet count. Sometimes patients might have immune thrombocytopenia. We've seen that before as a cause of uncontrolled menstrual bleeding. And then a ferritin to evaluate for total body iron stores. Documenting menstrual history is really helpful. So if you're the person who's really been kind of managing this patient throughout their course of heavy menstrual bleeding, and they've tried 3 or 4 different lines of therapy, having that information clearly documented from you is going to be maybe even easier than getting it from the patient. And evaluating for joint hypermobility is another thing that if you're really trying to look for something else that you can do in the meantime may be important. The way that that is done is through a Beighton score and a 5-point questionnaire. The Beighton score is really pretty easy. It's just 5 different physical exam activities looking for flexibility of the thumb, the pinky, hyperextension at the elbows and the knees, and then whether or not a patient can put their palms flat. I tell them to put it on the top of their shoes so that people aren't touching the medical examination floor, but basically by the book, it's putting their hands on the floor without bending their knees. The reason why this might be important is because there are very rare subtypes of Ehlers-Danlos syndrome, which can be of hypermobility is a very common feature of, where patients can have vascular aneurysms and other vascular abnormalities that can put them at really high risk for even sudden death and if an aneurysm rupture. So for most of these patients, we will recommend that they get an echocardiogram, and that might be something that you can do even in between your determination that they have an abnormal bleeding symptom and that it may be due to hypermobility and before we see them. It also kind of helps set the hematologist up for their next appointment too, because then we know to maybe dive into the secondary criteria, do a little bit more physical exam findings. Sometimes these patients will have very classic characteristics like unique folds of their eyes or elastic skin, really translucent skin. They can have prominent striae and little pisogenic papules on the back of their heels. All these things which may indicate a specific subtype or a higher likelihood of true EDS that should warrant referral to a geneticist. And then the next thing is evaluating for generalized, or sorry, I already said that, offering educational resources. So there's a lot of different things out there. HFA has a really great website that I really like, especially when it comes to kind of answering special questions like what do I do if I'm going back to school, and financial questions. They have some great education on there. A couple of other places that I like to refer patients to for additional information, especially if like, hey, this is a clear-cut von Willebrand disease patient. I'm giving this patient a diagnosis, but it's going to be 2 months until they see a hematologist to talk about it. This gives them a little bit of something to do to try to allay those anxieties about really not knowing what that means to carry that diagnosis. The CDC is another great place. They even have lots of different links to different educational resources. They have lots of videos. I think they have the best collection of videos that I have come across. And they also have a way that you could do a self-BAT on their website. And this other website too, Better You Know, I think is one of the most navigable that I've come across that also allows you to do a self-BAT. And I really like that they have this section of how to prepare for your visit, and kind of allows patients to come prepared with questions that they might want to ask. So I want to go back here, and the last thing I'll point out is in terms of things that you can do, once you've ordered a serum ferritin, if it comes back low, getting that patient treated with oral or, if appropriate, IV iron is really, really important. This is something that can improve a patient's symptom, quality of life, and overall, management of their underlying disorder, especially for teenage girls who are often faced with, anxieties, depression, fatigue. It's hard enough to be a teenager, and this is such a common problem that if you know to look for it, there are really easy interventions and ways to treat for it. I think even IV iron, that's not something that has to just be sort of kept by primary care and hematologists. This is something that even I think gynecology should feel empowered to refer their patients for. So what do we do in the hematology clinic? Like, what different things might we implement on top of hormonal interventions that could help treat menstrual bleeding symptoms? These would include antifibrinolytics, things like Amicar and Lysteta, and vasopressin analogs. This is DDVP, intranasal stymate, which used to be on the market and no longer is. This is a really useful medication that increases endogenous von Willebrand factor and factor VIII activity, and it can be used across several different disorders in von Willebrand disease, factor VIII deficiency, platelet disorders, and generalized joint hypermobility disorders. These are the two things that are, I think, really the most important for outside providers or referring providers to know exist, even if you don't personally feel comfortable in prescribing them. Because if someone's really having refractory bleeding and you kind of just know, like, I'm pretty sure that this patient's going to need an antifibrinolytic on top of their OCP, or really would need vasopressin or something else to, again, get their bleeding under control, at least just knowing that those are things that exist and are available so that you can help refer that patient even to an emergency room, kind of with an intervention that you think that they might need to be assessed for, can be really helpful for those patients who are doing poorly. Other things that we would use that I think are really best administered by a hemostasis specialist, but just so you know they exist, would be targeted factor replacement therapy. Most deficient factors do have a product that specifically can replace that missing factor. For those that don't, such as 11 and 5 and 10, we can use FFP or even cryoprecipitate. And then, of course, for really refractory bleeding or factor 7 deficiency, there is recombinant activated factor 7A. Like I say, I think the most important things, though, for this particular audience to know about would be these more first-line interventions for hemostatic therapy, which would be the antifibrinolytics and vasopressin analogs. When it comes to treating menstrual bleeding, I'm certainly not one to tell a gynecologist how to use their tools and their hormonal therapies to best manage. However, we do have really good evidence at this point in time in the hemostasis and gynecology community that has demonstrated that an IUD is by far and away the most effective way of managing heavy menstrual bleeding symptoms in patients with inherited bleeding disorders. Where even OCPs by themselves only work about 50% of the time. Antifibrinolytics like Lysteta, as previously mentioned, work about as well as OCPs, but IUD really has a much higher success rate. So this was a study that was led by Dr. Hughley at our center, specifically in people with bleeding disorders, wherein she found that patients with bleeding disorders had really good tolerance of an IUD and had a continuation rate out to 6 years. And most of these patients, 60 to 70%, were completely amenorrheic by 3 months, which there's just nothing else available that really compares to that. It is worth noting, though, that there was a pretty high rate of expulsion, which we've theorized is related to the heavier bleeding that patients with bleeding disorders experience around the time of insertion. And more certainly to come on that. All right, so we've talked about the barriers and what providers can do. There are a couple of things that you can also counsel your patients that they can do in the meantime before they're seen. It's really helpful if you tell them on the way out the door, like, hey, before you see the hematologist, ask around family to see if anybody else has bleeding symptoms. A lot of families really don't talk about medical history, and especially don't talk about something as sensitive as heavy periods. So mothers, cousins, aunts, grandmothers, they all may be having similar symptoms, but it's not guaranteed that that conversation has taken place before to know. So it's helpful if you can try to start generating that conversation so that when they are seen, they have a little bit more of that information. The other thing that's probably really helpful, or probably most helpful, is to do some period tracking. The Blood Sisterhood app has been really, really useful for this, and it is endorsed by HFA. My understanding is that this is an app that may not forever be available, but for the time being, it still is. And it's really, really helpful. It's one that probably best helps us to estimate not just duration of menstrual bleeding, but also volume. They can also go online and take a bleeding questionnaire, or the self-BAT. Both the CDC and the Let's Talk, and the, oh my gosh, I'm blanking on the name right now. Better You Know websites have questionnaires that they can take on there. But I personally think if you're just referring a patient to take an online BAT, that this is the most the easiest website to interface with. It's called Let's Talk Period, and it's out of Canada. So they have versions in English and French, which is kind of unfortunate they don't have one in Spanish. I think that's something that's currently lacking on the internet, in my opinion, but this really interface is nice, and it's easy for patients to click through, and it kind of gives them a chance to say, like, hey, I didn't realize that those nosebleeds I had were really all that normal, and kind of add everything up to give them an indication of their own bleeding severity. It's really helpful if you can guide them to make a list of questions. When we first see a patient, we really inundate them with a lot of information, especially if we think that they have a certain bleeding disorder and we're doing disease-specific education. It can be really overwhelming, and it's hard for patients to then think of questions when they're trying to digest all of that. So if they come prepared with things that they know they want to talk about and ask, that can be really helpful. And also, there are some restrictions out there on who patients can see where and what kind of medications they can get, what kind of labs will be covered, and having them check in about those things beforehand can also be really helpful. So that is the end of the presentation, and I'm happy to answer questions, is kind of my understanding, before we go into the cases.
Sorry, I was on mute. That was a great presentation. Thank you very much, Dr. Moyer, especially highlighting the things that both we as providers and patients can do before they get to you, the hematology specialist. So thank you for that. There was one question that popped up in the chat that I wanted to read out for you to answer. So, and it sounds like maybe patient really driven. When I had my periods, I used 3 tampons an hour and was borderline anemic. After college, I saw an OB who prescribed birth control, which helped me significantly. I've always bruised easily. I'm very fair-skinned. However, I had surgery to remove my gallbladder and surgery to remove an abscess in my jaw, and the doctors didn't mention any issues with bleeding.